A slideshow. Title, All of Us Research Program. Research Opportunity Announcement, Informational Webinar. ROA number OTA-23-003. Center for Linkage and Acquisition of Data, CLAD. Date, March 3, 2023, 1 to 2:30 p.m. Eastern Time. All of Us Research Program. NIH, National Institutes of Health. A woman appears in a video call at the top right-hand corner of the slideshow.
Hello, my name is Tamara Moore. I am the team lead for public relations at the National Institutes of Health All of Us Research Program. Thank you for joining us today for this pre-submission webinar to review the All of Us Center for Linkage and Acquisition of Data Research Opportunity announcement. Before we get started, I want to go through a few housekeeping items. All attendees are automatically muted throughout the webinar. If you have any questions during today's presentation, simply open the Q&A window and type your inquiry into the box and click send. Any relevant questions not addressed during today's webinar will be included in the Q&A document posted as an amendment to the ROA on sam.gov. And as a reminder, today's webinar is being recorded. Both the recording and the presentation slides and the Q&A document will be posted to the All of Us website at allofus.nih.gov, as well as posted as an amendment to the ROA on sam.gov in the coming weeks.
Slide. Today's presenters, pictures, names, and titles of 3 people.
Today, I am joined by my colleagues, Chris Lund, Chief Technology Officer of All of Us Research Program, Lou Berman, Branch Chief for Digital Health Technologies and Data at All of Us, and Jessica Ely, Team Lead for the Other Transactions Authority Specialist in the Awards Management Branch of the All of Us Research Program. I'll now turn the call over to Chris.
Chris Lund appears on the video call. Slide, webinar agenda. All of Us Center for Linkage and Acquisition of Data, a bullet point list.
Thank you, Tamara. I wanted to start off by pointing out what an extraordinary time that we are in right now, that as health data starts to become more interoperable, as we get better support both nationally at a federal level and from a technology perspective to gain access to people's health data, what we can do to drive a better understanding of human health and to create more precision medicine. And so I want to start this webinar off by giving a brief overview of the All of Us Research Program and to outline specifically the Center for Linkage and Acquisition of Data, or CLAD, Research Opportunity Announcement. You'll be hearing from some of my colleagues here as we go through, so let's move on to the next slide.
Slide, webinar opening.
Next slide, please.
Slide, opening, a statement.
So this announcement is to solicit and review proposals and evaluate potential partners and ultimately fund the future All of Us Center for Linkage and Acquisition of Data, or CLAD. Next slide.
Slide, All of Us Research Program overview.
So to look at the All of Us Research Program, next slide.
Slide, All of Us Research Program mission, a mission statement and list.
The All of Us Research Program is a historic effort to engage with 1 million or more people who live in the U.S. To collect information from them so that we can deliver one of the largest and richest biomedical data sets that has been available, to make that broadly available to the research community. This is something where we also are focusing at the same time on addressing that many people have not been able to participate in research in the past, and for us to reach out to communities that have been underrepresented, to engage with them, to share the data with the program that will allow us to deliver better healthcare to everybody by being able to recognize the different responses that people have to different treatment and medications. Next slide.
Slide, All of Us Consortium members, as of August 2022. A list of dozens of logos separated into groups.
The All of Us Consortium is quite large. We work with a number of different providers, including health organizations that help us to recruit and engage with communities that include both federally qualified health centers, academic medical centers, and regional medical centers, as well as the VA, that we work with technology partners that help us build the platforms that collect information from participants and engage with participants, take them through a consent process, return information to them. We have a biobank with the Mayo Clinic. We have a data and research center that helps us to curate the data and ultimately deliver that to researchers on a platform that provides broad access and the tooling necessary to do research. And we also have genomics partners that we work with to do the whole genome sequencing, as well as array data collections that we also use to return some information back to participants about their genomics. And we also have communications and engagement engagement partners that we work with to help explain the program and to help do outreach, and the participant center, which allows us to do engagement with participants who are not associated with specific health provider organizations. Next slide.
Slide. All of Us Community and Provider Partner Network, as of August 2022. A list of logos.
Additionally, we have a large community and provider partner network that again helps us reach communities that have been excluded in many cases from research in the past. For example, 50 Forward or the National Hispanic Alliance and PrideNet and others that reach out to communities that help us to bring in people that are sexual and gender minorities, people from races and ethnicities that are underrepresented, people with some sort of disability status, low income, rural populations, etc. Next slide.
Slide. All of Us aims to enroll 1 million plus participants who complete initial program opportunities. A line graph titled Enrollment Numbers, with 2 lines trending steadily upwards from May 2017 to August 2022. The lines represent participants and participants who have completed initial steps of the program.
We do have a goal to get to 1 million participants and more. We were doing quite well up until the pandemic started. And when we had to pull back in terms of our recruitment, since so much of our recruitment was done in person at healthcare organizations. But as you can see from this graph, we have started to recover the rate at which we were collecting in the past. And at this point, we have nearly 600,000 participants who are somewhere in the process of joining the program, and over 400,000 who have completed all the initial steps of the program, which includes biosample collection, which is both blood and saliva and urine, as well as filling out surveys about their health history, about their health habits, etc. And also to collect electronic health records for those participants. And so we get permission from the participants to collect health information on their behalf. For those participants who have come into us through health provider organizations, we have worked with them to have the data transcoded into OMOP and shared with the program to be centralized and then shared with researchers. But because we do have that authorization to go collect additional information on their behalf, this award is going to be largely about our opportunity to go out and link additional data in that will enrich and enhance the data set for the sake of research. Next slide.
Slide. All of Us supports regional enrollment centers and nationwide virtual participation. A map of the United States, with the states highlighted in different shades of blue.
The engagement that we have with different regional enrollment centers and our national virtual participation opportunities has allowed us to collect data from people who are enrolled from all 50 states and through a number of the territories as well, including Puerto Rico and Guam. We have worked to try and make sure that we're filling in any gaps that we have so that we really cover the entirety of the country for everywhere that people live, so we get a better understanding of American health regardless of where it is. We also do provide all of our material in Spanish as well as English. Next slide.
Slide. All of Us strives to enroll a cohort that reflects the diversity of the. A pie chart titled Race and Ethnicity of Participants, and a list of percentages of different populations, titled UBR category.
When the program started out, we set out to make sure that we were reaching out to people that were underrepresented in biomedical research, or UBR, and set a goal to get at least 80% of the people who were fully enrolled in the program to be underrepresented for some reason. That could be their age, race, or ethnicity, their sex or gender identity, their educational attainment, income, geography, disability. And then we also wanted to make sure that at least half of the people were people that were from races or ethnicities that had been traditionally underrepresented. And we have done pretty well in this regard. We are close to 50% for race and ethnicity, and that we are over 80% for people who are underrepresented for any reason, having had great success in reaching out to Black or African American or African communities, as well as Hispanic, Latino, or Spanish communities. Next slide.
Slide. Data on the researcher workbench is diverse and longitudinal. A list of statistics and a chart showing the increase of data collected from 1980 to 2020.
And in the course of doing that, we have collected the data, as I'd mentioned, which includes both the electronic health records surveys, but we've also given Fitbits to some participants and have invited people who have Fitbits to connect that to the program, as well as Apple devices. And then we have also collected physical measurements for people that have come in to be recruited at health organization centers. And I think what's particularly interesting about that is that we've also found by doing so, we have ended up collecting data that predates the program. And so people who connected their Fitbits to the program, who'd been wearing their Fitbits for 10 years, that we got that data all the way back to the start of them wearing those Fitbits. The electronic health records precede the start of the program as well. And so you can see on this chart that data density going back in time, that we have, procedure information, condition information, drug information that goes back all the way into the 80s. So that the program at this point has not begun pediatric enrollment, although it intends ultimately to enroll pediatric participants as well. But you can do some amount of pediatric study with the data that we have just because of the history of the data that we've already brought in. Next slide.
Slide, Center for Linkage and Acquisition of Data, CLAD, a list.
So I'm about to hand over to Lou, who will walk us through the construction of this award, but I just wanted to close by sort of pointing out that the program at this point, 7 years into our operations, has done a wonderful job of outreach and engaging with this broad community, returning value and information to them. And we've collected a lot of data and already have research and papers coming out on that. But we see an additional opportunity here to go enrich the data that we have by connecting all the data that can be linked in for participants into this data set that we already have, so that we get better understanding of things like environmental factors, so that we really fill out all the aspects of their electronic health records. And that this is an opportunity not only for our program, but broadly for the NIH, that this is, I think, really going to be a bellwether effort that is going to show us how can we do more work to collect all of the data that's already out there for the sake of bringing it together and really driving precision medicine. And so with that, let me hand you over to Lou Berman, who is the branch chief for digital health technologies and data for the Division of Technology and Platform Development. Take it away, Lou.
Lou Berman appears on the video call.
Thanks, Chris. And with that description and that opening, this is going to be a hard act to follow. But thank you for preparing and providing background to the program. So today for CLAD, we're going to go through a number of things. I'm going to walk you through the vision for this ROA, what the current state is in the program. And Chris has already alluded to some of that with the different data streams that we're collecting. But in addition to that, we're doing some experimental work with data linkages, and we want to walk you through some of that. We'll talk about the data flow and where CLAD fits into the ecosystem of all of us, the key functions and operational goals of CLAD, what the cores are, and how we see staffing of each one of those cores. You may have some different thinking, but we want to share with you what our thoughts, some of the milestones within this project and how they fit together, we think, neatly, and where there are some repeatable processes that we want you to think about as you're putting together your proposal. And then lastly, we're going to walk through some of the factors that are affecting data linkages, because there are some dependencies, and you need to think carefully about how to construct your proposal and how those dependencies operate together. And then lastly, we've also had some questions about the optional periods, and there isn't a lot of definition behind that, and we want to give you some of our thoughts and ideas with where we see CLAD going and how you can contribute to the future of CLAD. Next slide, please. Oh, I think we went one. Can you go back up one slide?
Slide, the overarching vision for CLAD, a statement and a timeline from birth to 80 and over for a single person.
There we go. Right. So the overarching vision of CLAD. A key goal of the All of Us program is to build a broad data set, including behavioral, biospecimen, environmental health, and other data over an individual's life course. This data accounts for modifiers of health, such as individual mobility, where people live and work, where they seek care, and environmental exposures. An important aspect of this vision is a recognition that new data acquisition methods are needed that reduce participant burden. And you've probably seen through the ROA, one word that keeps popping up is passive data collection. And that really is about reducing participant burden. We don't want the CLAD award to be an award where we have to go back and engage with participants. They're already doing a lot of work with the program. We want to reduce that burden on them and link new data sets that will fill in the life course history of our study participants. So as illustrated here, we've got, life course, it's a longitudinal study. And over that course of a person's life, they may have moved. Mobility is a big factor. And in that mobility, they may have been exposed to a number of different things. They may have had different interactions with the healthcare system. And we want to fill in those gaps in the record that we currently do not collect. Next slide, please.
Slide, streams of data currently collected on All of Us participants. 6 bullet point lists titled Demographics, Surveys, Physical Measurements, EHR, Bioassays, and Physical Activity Data.
So Chris did a really great job describing the amount of data that we currently collect in the program, and there is lots of data across many different streams. For example, we collect demographic data, and it's fairly extensive. We do a number of surveys with our study participants, 7 or 8 different surveys that are asked, lots of questions that are incorporated into those surveys. We've asked a number of surveys related to COVID. For those participants that enroll through healthcare provider organizations, we also capture physical measurement data like blood pressure, heart rate, et cetera. Chris also described that we collect electronic health record data, and that comes right now through 2 primary different pathways. One is getting the data, the EHR data, through those HPOs. But secondly, we have a number of participants who are really great and willing to share data off of their iPhone, if they have an iPhone, through their Apple Health records. And secondly, they can connect their phone through their to a portal from their provider, and we can also access their EHR data there. And we do bioassays, and we do whole genome sequencing for some study participants, and certainly we hope that'll go up to all of our study participants. And in addition, we also collect physical activity data, primarily either through Fitbits, which are distributed on the program, or for those participants who share their wearable device data. Next slide, please.
Slide, Experimental Work with Privacy-Preserving Record Linkages, PPRL. A bullet point list.
But we've been doing work already with linkages. We currently link some data into the program from the American Community Survey, but we've done a good bit of work with privacy-preserving record linkages, PPRL. To date, we've done 2 experiments. One of them is a fairly focused study at NIH with the National COVID Cohort Collaborative and the National Heart, Lung, and Blood Institute, where we were looking at something called cohort discovery to assess how much overlap there is between all of us and 2 other studies. We've also done a study looking at a very large claims database to assess how complete our EHR data is. And we're about to launch a 3rd PPRL study where we could potentially acquire additional EHR data for our study participants through the Cerner Learning Health Network. And we're also thinking right now about doing a 4th experiment where we would connect to a large imaging repository and bring in imaging data. So we've got a lot of work going on in this space, and we've learned a lot through these experiments. One thing that we've learned, and is really important, is that we need some verifications for matching accuracy, and we want to incorporate that into CLAD. And we think this is really important for 2 primary reasons. One, any of the data that goes into the researcher workbench that comes from CLAD, we want to make sure it's connected to the right study participant, because that affects research results. But secondly, some of this data may go back to study participants as a return of value. And if we're going to be linking in data from CLAD to our study participants and it ends up going back to study participants, we certainly want to make sure we're returning the correct data to them. And then secondly, another key factor to think about is that we've learned from this is that we need robust tokenization. And what we mean by that is that there's a recognition that when patients seek care and they're seeking care through the health system, this can result in different demographics. Their names can be spelled differently. It may be first name and last name. They may have changed addresses, et cetera. So we need tokenization tools and methods that are robust and can take into account those changing demographics. Some of the key results from the 2 studies that we've completed so far is that on the discovery effort, the cohort discovery effort with N3C and NHLBI, now this was a fairly small overlap assessment, but we were really pleased to find that close to 20,000 of the All of Us participants were located in the N3C initiative. And most importantly, we found that some of our participants were in a fairly large health information network. And that gives us hope that one of the milestones as part of CLAD, which is to connect to a health information exchange and a health information network, we'll be able to do that successfully. And then secondly, from the EHR completeness project, we learned that there's a significant amount of patient activity going on across diagnoses and procedures and drugs that's not currently captured in our EHR database. So making that connection to claims data and finding other robust methods to bring EHR data in will be really important to CLAD. Next slide, please.
Slide, Data linkages during the base period, a bullet point list.
So in the ROA, you probably noticed there's, of course, 6 different linkages that we want to execute during the base period. And those data linkages fall into three primary groups. There's clinical data. We want to capture mortality as a primary endpoint. We're really interested in incorporating healthcare claims data. And we want to start an experiment, a pilot study with health information networks and health information exchange as this additional method to fill in the gaps in our EHR data. The second big area that you'll see in the ROA is that we want to capture geospatial data. So we're going to start with capturing residential history for our study participants. We want to go back at least 10 years of residential history. Frankly speaking, we'd like to go back as far as possible. And we'll utilize that residential history to geocode that information. So we want to capture the latitude and longitude for where somebody lives. We want to get census block, census tract, et cetera. And then we'll utilize that information to do other linkages, both in the base period and down the road. And for example, the environmental data, the primary data set that we're interested in right now, is the Environmental Justice Index data from the CDC. And in order to bring that data in, we'll need the residential history and geocode information. And you'll see later in my presentation that there are some dependencies here, and we want you to think very carefully about that as you put this proposal together. Next slide.
Slide, CLAD data flow and researcher access within the All of Us data. A diagram showing 3 cylinders labeled merged OMOP datasets, merge raw data, and curated data, with data flowing into the first 2 cylinders. The third cylinder points to a pyramid titled Data and Research Center, consisting of 3 tiers labeled Controlled, Registered, and Public. An illustration of 2 people, titled Investigators, points to the pyramid.
So how does CLAD fit into the ecosystem? We've gotten some questions about this, like this is just one piece of the big puzzle, and what does this puzzle look like? Well, as Chris described and I described earlier, there are a lot of different moving parts to all of us and a lot of different data streams that are coming in. And so, for example, from our healthcare provider organizations, we're getting EHR data, demographics, survey, physical measures, et cetera. But if you were to look at the Data Research Center, and this is a really reductionist, simplified view, it's much more complicated than I'm describing here in this illustration. But essentially, we've got EHR data coming in as OMOP files. All of this data is going to be merged into a raw data repository, and then that data is curated. And from there, it's de-identified and moved out, so it's made available for public access in a very limited way, primarily descriptive statistics. And then it's moved into 2 other tiers, our registered and controlled tier, where access to that is really carefully controlled. People have to go through training, organizations have to sign agreements, et cetera. And CLAD is one piece of this puzzle. It's bringing in new linked data into that merged raw data repository. It'll be further curated and out to the DRC. One of the things you've probably noticed in the ROA, though, is that we don't want to just add more workload onto the DRC. They've got a tremendous effort underway. They're doing a really superb job, but we want to ease the burden on the DRC. And so our hope is that through CLAD, we'll be able to curate that data, and not only curate the data and make it, produce it in a format that's easy to ingest into the curated data repository, but we also want to produce documentation, really thorough documentation with each data set. And we want to provide tools for researchers so that when they go out to the researcher workbench, they not only get access to the data, but they get somewhat of a jump start in analyzing that data. Next slide, please.
Slide, CLAD operational goals, a bullet point list.
So what are the set of CLAD operational goals? And we really want you to focus on this first couple of bullets here. First, we don't look as CLAD as just the development of some software platform. We really want to build a center here, and we want that center to focus on driving value for researchers, and we want to bring new advanced methodologies and technologies to that center. Secondly, we think in order to do this, we're going to have to bring in really great folks, really good personnel and services for data acquisition, governance, and quality. De-identification is a key aspect of the work that's going on here, and we really want you to bring de-identification expertise along with expertise in data linkage. The ROA base period linkages, as you've seen, there's a number of new data streams, and so of course we want to bring that data in, but we also want to work on existing data streams. And so the HIE pilot is a method for us to bring in EHR data and amplify what we're doing. In doing all this data, and as I alluded to before, some of the work that we've focused on with our PPRL activities has really made us think about how do we ensure we've got a correct match? How do we know that when we do a linkage, we're identifying the right participant and linking in the data properly? So we'd like you to think about the rationale and the mechanism that we can use for ensuring we have high sensitivity, specificity, and then positive and negative predictive values. Of course, underlying all of this is a secure cloud-based data linkage platform. We're not coming into this platform with any specific idea on which platform that should be. We're really neutral to this. It could be something built from scratch. It may be something that you already have and you need to customize it in some way for CLAD. And then lastly, as I said earlier, not only are we interested in the data, but the documentation and tools for dissemination out to the researcher workbench. Of course, that's the core of what we're doing here. And we're really focused on having tools that researchers could use once they get into the workbench. Next slide, please.
Slide, core functions and key personnel. 4 text boxes arranged in a rectangular pattern, titled Research Management Core, Data Linkage Core, Data Platform Core, and Program Compliance Core. All 4 boxes point to each other and contain lists of job titles. A bullet point list appears next to each box.
So the way we've constructed CLAD, we've got 4 different cores that we think CLAD requires. First, we've got the Research Management Core sitting at the top and the Program Compliance Core at the bottom. Of course, we've got the Management Core, which will drive and oversee the work that's going on within CLAD. We've done something a little bit different than you may see in other ROAs in that we've tried to really elevate the work of de-identification and security, and we thought that really required its own core. So we've got a Program Compliance Core, and then in the middle here, we've got kind of the meat of the work that's going on. This is the computational plumbing that's going on within CLAD. We've got the Data Platform Core that will be used to curate all of this data, and then the Data Linkage Core, where all the work will go on for acquiring, ingesting, curating, documenting the linked data, and producing tools. One of the things that you'll also see in the ROA is that we've identified a number of people or positions that we think are really key. We've got 2 within the Research Management Core, a principal investigator that we hope will have strong experience doing these kinds of linkages and understands all the scientific, technical, and methodological work that needs to be undertaken within CLAD. The program manager, of course, is going to be particularly important to this effort. Within the platform core and the other cores, we've identified core leads and then specific roles within those cores that we think are really necessary to execute this work. Having said that, we've also provided offerers with the opportunity to identify other key personnel that you think are required to drive this, or different personnel. If you think that we haven't correctly identified the people that are key to leading this effort or executing the work, please note that in your proposal and provide a rationale for why you think there are differences from who we've identified as the key personnel. Next slide, please.
Slide, CLAD milestones and relationships. Text boxes titled Milestone 1 through Milestone 12, arranged in 2 rows with Milestone 12 in between.
So the milestones have been developed in a very specific way. And I think you'll see how they're lined up as we walk through this slide. So the first 2 milestones are kind of the preparatory stages, getting the awardee on board, walking through the regulatory and policy related issues. Milestone 3 and 4 is going to be all the work related to getting the data linkage platform up and operating, getting it into a state where it's ready to take on data for the linkages, getting it through and having the authority to operate. On the bottom, we've got a number of milestones. Those are all related to the data linkages, but there's another milestone there, number 5, which is related to data quality and governance and sustainability. And we'd like you to have plans prepared as part of this effort for ensuring that we've got great data that we're putting out onto the workbench. We've got appropriate procedures around data governance, and we've got a sustainability plan for the long term related to all the linkages that we're doing. In the middle of this slide, you see we've got milestone 12, and we'd like you to think very carefully about that. We think of the awardee as a real partner, a collaborator. There's a lot of really important work that has to go on with CLAD. The relationship to the DRC is particularly important, but you're going to be a really strong partner with the All of Us research program. And so we don't want to just execute work on CLAD. We really want you to help us think through what the future of CLAD is. And so that's why we've added this milestone here, milestone 12. We would like this to be a 2-day meeting every year. And during the course of that two-day meeting, the first day would be set up to walk through what we've done well during the first year, during the previous year of CLAD. What could we have done better? What mistakes did we make? And what can we learn from that moving forward? On the second day of that two-day meeting, we'd really like to structure that meeting in a way that we can think about the future of CLAD. What differences do we need to make in the data linkage platform? What new data linkages should we make? Are there new strategies with respect to de-identification? We'd really like your thoughts and input on that. We would like to ensure that we bring in not only all of us research program partners for that meeting, but we'd like to bring in folks from academia, from industry, and certainly a number of folks around NIH who can really help us think through the future of CLAD. Next slide, please.
Slide, repeatable pipeline within data linkage milestones. A 4-step process. Step 1, identify linkage. Step 2, assess blockers and scientific merit. Step 3, repeatable data linkage pipeline. Step 4, end. Step 3 consists of 6 text boxes, organized in 3 columns, titled Objective 1 through Objective 6 and 7.
So, as you've gone through the ROA, one of the things that you might have seen is that for each of the 6 data linkages, there's sort of a repetitive process. There are a number of objectives that repeat over and over and over. And as we went through each of the data linkages, we thought, well, gee, this is going to start out with gathering requirements. And even though in your proposals, you will propose a data source for each one of those linkages, we certainly want to walk through that with you after the award. Secondly, you've got to procure data. That's the second objective. The third objective will be to configure and test the data linkage platform with respect to each one of those linkages, ingest and ensure that there's quality related to that data, development of the analytic tools, and then lastly, the transfer of those data tools and documentation over to the DRC, and provide technical support that may be required once the data is out on the researcher workbench. We really think that this could become a repeatable pipeline for each data linkage, and we'd like you to think about that as you're developing your proposals. We really hope that it will work this way to the greatest extent possible, and that for future linkages, when we get to the optional years, we'll be able to reuse a lot of the learnings and tools that have been developed to acquire and process and just curate the data as part of CLAD. Next slide, please.
Slide, some factors affecting data linkages. A bullet point list.
So there are a number of factors that are going to affect the data linkages. And first, for each one of the data linkages, we will require that there be a submission to the Institutional Review Board. And of course, we'd like you to help in the development and be responsible for the development of that submission and any questions that may come back from the IRB with respect to each one of those linkages. Before we can proceed to acquire data from the Data and Research Center, link data, we've got to have an authority to operate, so we'd like you to work on that and get moving on that as quickly as possible. We have a really strong security team as part of our division, and we're ready to get moving with that. You'll see as you engage with all of us that there's a lot of moving parts to the program, and in all of those moving parts, there's some alignment that has to go on with how we move data out into the researcher workbench. We are moving to a process where we plan on doing production in such a way that there will be data sets going out on a yearly basis. There will also be some out-of-band type production of data going out to the workbench, but we'll need to align the CLAD data deliveries with the work that's going on in the workbench in those time schedules. And then lastly, we do have less than about 1% of our study population does withdraw from the program. And we want you to keep that in mind. As participants withdraw from the program, we may have to destroy data that sits in CLAD, and we may also have to preclude certain data from going over to the DRC. And we want you to think about that and plan for that as part of your proposal. Next slide, please.
Slide, dependencies within the baseline data linkages. A flowchart consisting of text boxes labeled milestone 6 through milestone 11, with the final box containing the text CLAD data linkage platform.
So I mentioned earlier that there are some dependencies that we need to think about, and you can sort of put mortality data and healthcare claims data off to the side, and not to say that there isn't a lot of work involved with that, of course there is, but the biggest dependency that we're thinking about is with respect to the residential history data. Once that data is acquired, of course, it's required, and we've got to acquire that data in order to do geocoding. And in order to do linkages to the environmental justice index data, we've got to have geocoded data. So think about those 3 pieces and how they fit together. You may design the pilot study for the health information networks and health information exchanges in a variety of different ways. We're not wedded to one specific way to do that pilot. However, depending upon the way you construct that pilot, you may need address information for study participants. And if you do, then you have to take that into account when you design that pilot and when you lay out the timing for each one of these linkages during the base period. Next slide, please.
Slide. 1-to-M relationships exist between residential address and data linkage. A timeline for a patient, from birth to death, with each point on the timeline labeled with a different location. The data for each location consists of residential history, geocodes, environmental, and HIN/HIE pilot, possibly. N/A, no data available, appears for some data points in some of the locations.
The thing to think about is that there are some complicated one-to-many relationships. And as I mentioned, we have this dependency on residential history for producing geocodes, for tying the geocodes into environmental data. But don't think of it as just sort of a spot in time, one piece of data that you're doing a linkage with. In this example, what I'm trying to illustrate is that we have a study participant, Althea Dumas, and Althea may have lived in many different locations, 4 of which are identified here. She was born in Norfolk, moved to Davidson, North Carolina at some point of her life, moved to College Park, Maryland, moved to Harrisonburg, Virginia, where she died. And each of those residential addresses are really important to doing the geocoding and to doing the environmental justice index linkage and potentially to the pilot. So there are multiple pieces of data that you have to link up as part of this effort, and a variety of different data that are all going to come together as part of this research data set that goes over to the DRC. So think about that carefully. There may also be pieces of information that are not available. For example, the environmental justice index data for the data that's collected as part of EJI, there aren't always data available at every location around the United States, and they're not collected every year. So you're going to have to, it's sort of like playing multi-level chess. There's data that come in at certain times, there are data that are not available in certain locations, and you're going to have to think about how to carefully link all of that data up with respect to residential history. Next slide, please.
Slide. Alignment of source data provider updates, data acquisition and production. A chart labeled Data Production Schedule for delivery of data to the researcher workbench, showing 4 calendar years.
The other thing that comes in that you'll have to think about is for each of the data linkages that we plan on doing during the base period, and even during the optional periods when we decide on what those are, those data sets are going to be updated at different frequencies by the producer of the data set. And some of them occur less frequently, some of them are probably occurring more frequently. So for example, people tend to move in the United States over the course of their life. They may move about 11 or 12 times. Most of those moves tend to be within the same city or county, state, less frequently out of state, but they do move. Nonetheless, when you think about those movements over the course of the year and producing a data set for CLAD and moving that out to the researcher workbench, it's probably not going to require you to do many pulls on residential history for our study participants during a given period of linkage. On the other hand, healthcare claims data and EHR data may be updated frequently. People are seeing their doctors often, and in that case, there's a lot more data that would be available for a linkage, and you'll have to think about how to align all of that data coming in for healthcare claims with when we want to put data out onto the researcher workbench, or when we want to deliver it to the DRC and when it goes out to the researcher workbench. We'll go through all of those requirements fairly carefully for each one of the linkages, but there's a lot of things that need to be synchronized as we do these linkages. Next slide.
Slide. Optional periods. 2 bullet point lists.
So the optional periods. What are we planning on doing? Well, we haven't decided on what the option period linkages will be yet, but there are a number of things that we are thinking about. For example, and Chris described this earlier, we're really interested in environmental data. We've got a really strong partnership with our colleagues at the National Institute of Environmental Health Sciences, and we plan on incorporating more environmental data over the next couple of years. We're really interested in imaging, and we're working very hard right now on developing a strategic plan for imaging data and waveform data. And in fact, I think about 2 months, we'll be putting together a workshop on how to capture eye-related imaging. And in addition to that, there may be other data like registry data, cancer data, immunization data that would be really important to incorporate into the workbench. But what's driving these decisions? It's kind of like real estate, research utility, and more research utility. We don't want to just collect data for the purpose of collecting data. It's really got to add value to the researcher workbench, and it's got to drive utility. Secondly, it'll be dependent on funding and how much funding we have in the option periods to execute this work. We're really we're really keen on CLAD milestone 12, as I described earlier. We really want your input into thinking about future linkages to make. And then we've got a really vibrant group of partners in the program, which have really done a great job in providing input to the program. And we've got a steering committee, science committee, and lots of other committees, and lots of interest across NIH in this activity. So we anticipate all of that will be feeding into what drives the work that we'll be doing in the option periods. And then lastly, and most importantly, Chris described earlier that we have a primary principle on this program in ensuring that we represent people who have been traditionally underrepresented in biomedical research. And so for us, driving decisions isn't just about doing science and having research utility, but it's also about ensuring we meet the expectations of the participants in this study. Next slide.
Lastly, thank you.
And lastly, I want to thank everybody. This has been a long time in coming, getting this award out, and we've had meetings as part of our discovery exercises and market research over the last year and a half. And many of the people who are on this call, in fact, have been really gracious in offering your time, offering your advice to us. In fact, between the notice that went out and the research opportunity announcement, we had meetings with many of you. And we're really grateful for the time that you provided and for your advice. It really helped us learn more about how we should do this work and how we should execute it. And we really look forward to working with you in the future. And so with that, we're going to move on to the next portion of this webinar.
Submission requirements and timeline.
And I want to introduce Jessica Ely. She is going to talk about the submission requirements and timeline for the ROA. Jessica, all yours.
Jessica Ely appears on the video call. Award information, a bullet point list.
All right, next slide. Thank you, Lou. As Lou said, I'll be going over the submission requirements and timeline for the CLAD ROA. The award type for the CLAD effort will be an other transaction, or OT. An OT is not a grant, cooperative agreement, or contract, but instead uses other transaction authority. Awards made under the other transaction authority are not subject to the NIH grants policy statement, uniform guidance, or the Federal Acquisition Regulation, unless certain provisions are stated in the other transactions awards terms and conditions. Other transaction awards are a unique legal instrument, subject to the authority and the terms and conditions contained within each award. We are utilizing the other transaction authority for this ROA to provide us with more flexibility in the award selection process, in the negotiation of terms and conditions, and during post-award administration to allow us better to meet the needs of the program. To learn more about the other transactions, please refer to the link provided in section 3.1 of the CLAD ROA. The anticipated OT award will be made pursuant to the other transaction authority granted to the NIH director under the 21st Century Cures Act, as specified in section 402N of the Public Health Service Act. The total base period cost for CLAD, if all milestones are funded, is anticipated not to exceed $30 million. The base period of performance for CLAD is 18 months. There may be up to 4 12-month optional periods, and the NIH reserves the right to extend the period of performance beyond the negotiated period. Next slide, please.
Competition process, a bullet point list.
The ROA for CLAD includes 3 phases. Phase 1 will consist of the submission and evaluation of full technical and cost proposals. Phase 2 will consist of the demonstration and evaluation of data linkages platform capabilities. And phase 3 will be the negotiation and award of the OT. A down select will take place at every phase, with one award anticipated to be made in phase 3. Depending on program requirements, we reserve the right to omit phase 2 or to combine the phase submissions as needed. Phase 1 is open to all, and phase 2 and 3 will be invite only. Further instructions for phase 2 and 3 will be provided in the invitation to those who for those phases. You must submit a full technical and cost proposal in phase 1 to be eligible for an invitation to phase 2 or 3. Next slide, please.
Letter of intent, a bullet point list.
We are currently requesting that offers who intend to submit a proposal in response to the CLAD ROA complete the intent to submit proposal form, which can be found in Appendix E of the ROA. Please Complete this form and return it via email to the All of Us DTPD Awards Requirement and NIH.gov by March 15th, 2023 at 3 p.m. Eastern Standard Time. The intent to submit proposal form is not binding and does not enter into the review of a subsequent proposal. The information submitted in the form allows the All of Us research program to estimate the potential review workload and plan the review. Please only submit the information requested in the intent to submit proposal form. Next slide, please.
Slide, Phase 1 Proposal Submission Instructions. A bullet point list.
Phase 1 proposal submission instructions can be found in section 8.1.1 of the CLAD ROA. The full technical and cost proposal must be submitted via the NIH ERA Assist system. Here are a few things you need to know about submitting proposals in the ERA Assist system. To submit a proposal via Assist, the applicant organization must be registered in ERA Commons. Please plan accordingly, as registration approval does not occur immediately upon request. Organizations are already registered in ERA Commons do not need to re-register. The individual or individuals with the role of signing official and program director principal investigator must be affiliated with the organization and have ERA Commons credentials to complete the submission process. When submitting your proposal, use the ROA number OTA-23-003 in the field requesting funding opportunity announcement number. Instructions for submitting a proposal in ERA Assist can be found at the link provided, and there's also a link to the instruction guide for NIH OT applications in ERA Assist in section 8.1 of the CLAD ROA. ERA technical help is available at the link provided at the bottom of the slide. Next slide, please.
Slide, Phase 1 Proposal Submission Instructions. A bullet point list.
The Phase 1 proposal submission instructions can be found in section 8.1.2 of the CLAD ROA. The proposal must be on 8.5 by 11-inch paper with 1-inch margins on all sides. It must be single-spaced and in 12-point Times New Roman font. Smaller text for charts, tables, figures, and illustrations are acceptable as long as legible when the page is viewed at 100%. Figures and illustrations may be in portrait or landscape mode. Adobe PDF files are required for ERA Assist submissions. Excel files must also be submitted in PDF format. We may later request the Excel file via email if it is needed during the evaluation. No hard copies, faxes, zip files, or password-protected files will be accepted. Only one proposal submission is allowed per an offer. Next slide, please.
Slide, Phase 1 Proposal Content Requirements. A bullet point list.
The Phase 1 proposal requirements can be found in section 8.1.3 of the CLAD ROA. Section 8.1.3 provides a description and further direction for each section shown on the slide. I'm not going to go over every section, but did want to highlight some areas. Please pay careful attention to the page limitations set for each section of the proposal. The cover page, table of contents, and cost proposal do not have a page limitation or count against the overall page limit. The abstract and specific aims are limited to 1 page each. The abstract and specific aims will not be evaluated, but these sections are a requirement to enter the proposal into ERA Assist. The team structure and partnership section shall not exceed 2 pages. The leadership and management plan shall not exceed 2 pages. The technical approach shall not exceed 17 pages. And a milestone is required in the table format described in section 8 of number 8 of section 8.1.3. The milestone plan shall not exceed 3 pages. The estimated costs in the milestone table are high-level cost estimates for each milestone and should match directly with the milestone cost statement in the offer's cost proposal. The relevant past experience section shall not exceed 3 pages. And the proposal must contain a key personnel overview, which will be a short synopsis of each key personnel and their roles, responsibilities, and experience. The key personnel overview shall not exceed 3 pages. We have provided a list of key personnel and minimum level of effort for each core in number 10 of section 8.1.3. An offer may identify an alternative list or additional key personnel and their associated LOE to successfully execute the work. An Appendix A to the key personnel overview is required that contains key personnel NIH bio sketches and resumes. The NIH bio sketches are limited to 4 pages each, and the resumes are limited to 2 pages each. But the bio sketches and resumes in Appendix A do not count against the overall 32-page limit of the proposal. Next slide, please.
Slide, Phase 1 Proposal Content Requirements. A bullet point list.
Finally, proposal submissions must contain a cost proposal that includes a cost narrative and cost breakdown to complete each milestone in the milestone plan submitted. A cost breakdown sample is provided in Appendix F of the ROA. The breakdown of each milestone should include the following as described in number 11 of section 8.1.3. It will break down and show personnel cost, costs for each subaward. Please note that all subawards shall provide a separate cost breakdown and narrative per milestone at the same level of detail required for the prime. Other costs that should be broken down in the cost proposal include the consultant costs, travel costs, material and equipment cost, other direct costs, indirect costs, and any profit or fee if proposed. Cost breakdowns must show cost allocated to each of the 4 cores in section 5.2 of the ROA. Next slide, please.
Slide, Phase 1 Proposal Evaluation Criteria. A table, with 3 rows, labeled each core, each data linkage, and schedule, and a bullet point list.
The Phase 1 Proposal Evaluation Criteria can be found in section 8.1.4 of the CLAD ROA. The full technical proposal evaluation will be across all 4 cores, each of the linkages, and the milestone schedule. Each core will be assessed along 4 dimensions. The team proposed, an understanding of the NIH and the All of Us research program missions, challenges to be addressed by CLAD, and the interrelationships between program partners. They will also look at the science and technology capabilities required to produce a data linkage solution that addresses current program needs and enables future growth. They will also look at past experience of similar working environments comparable to the All of Us research program. Each linkage will be assessed along 3 dimensions, including the data acquisition preparation, which is the proposed requirements analysis plan, a candidate data resources, and the process for the IRB review and material preparation. Another dimension looked at is the platform preparation and ingestion, which is the proposed process and procedures for the data linkage platform, specific configuration testing, production data ingestion, and the quality control. And finally, they look at the effective documentation tools and assistance, which is in the proposed analytic tools and documentation to be discriminated to the DRC and research workbench. It also describes training and technical support. The schedule, which is the milestone plan submitted in the proposal, will be assessed for the ability to satisfactorily meet the schedule of milestones. The cost proposal will be assessed to determine if the cost proposed is within the available funding limits and the ability and likelihood of the offer to successfully execute the proposed approach within the financial resources proposed. Next slide.
Slide, Phase 1 Proposal Selection. A bullet point list.
Information on the Phase 1 proposal selection can be found in section 8.1.6 of the CLAD ROA. A numerical scoring system will be used in the technical evaluation of each proposal. Evaluators will score each proposal on 3 elements: cores, linkages, and the milestone plan, to produce a composite score for a proposal. The overall cost proposed will be given a rating of insufficient, sufficient, or excessive as described in section 8.1.5 of the CLAD ROA. Offers whose full proposals are deemed to have significant merit will be selected and invited to provide a demonstration in Phase 2. The MIH does not intend to provide feedback or debriefings on proposal submissions, but offers will receive notification should the All of Us research program decide not to provide an invitation for the next phase. Please note, to be eligible for an invitation to sequential phases and award, offers must submit a proposal in Phase 1. Next slide, please.
Slide, Phase 2 and Phase 3. 2 bullet point lists.
Information and guidelines for Phase 2 can be found in section 8.1 8.2, of the CLAD ROA. These guidelines are subject to change. Phase 2 is by invitation only. The primary purpose of the Phase 2 capabilities demonstration evaluation is to better understand the composition and abilities of the offer's team, to assess security readiness, and to demonstrate the offer's DLP. Details of the Phase 2 demonstration will be provided to the offer in their invitation for Phase 2. Upon completion of Phase 2 evaluations, the NIH intends to select one offer to proceed to Phase 3 for negotiation and award. Information and guidelines for Phase 3 can be found in Section 8.3 of the CLAD ROA. These guidelines are subject to change. Phase 3 is also by invitation only. Upon favorable evaluation and availability of funds, we will proceed to negotiation and award with one offer to make an OT award in Phase 3. Next slide, please.
Slide, approximate timeline to award. A timeline starting February 15, 2023, and ending September 1, 2023, with 8 points. 1. ROA released. 2. Proposal preparation and submission. 3. Phase 1 proposal review and selection. 4. Phase 2 invitations delivered. 5. Interval description. 6. Phase 2 offer demonstrations. 7. Phase 3 selection and negotiation. 8. Award.
This slide shows a tentative timeline to award. These are estimated dates and are subject to change. Phase 1 proposals are due April 17th, 2023. It is estimated that the Phase 2 invites will go out around June 7th of 2023, with Phase 2 demonstrations being held the week of July 24th to July 28th. The award of the CLAD award is anticipated to be made around September 1st of 2023. Now back to Tamara for questions and answers.
Slide, questions and answers. Tamara appears on the video call.
Thanks, Jessica. At this time, we'll be moving to the question and answer portion of the briefing. As a reminder, questions and answers about this research opportunity announcement will be posted as an amendment on sam.gov. This includes any questions that were submitted during this webinar that are not addressed during the presentation. After the webinar, there is still an opportunity to submit your questions. Questions must be submitted to all of us DTPD award requirements. We'll put that in the chat. At least 14 calendar days prior to the proposal submission deadline of April 17th. If submitted less than 14 calendar days from the deadline, they may not be answered. So let's get started.
Slide, questions and answers, security and clearances. A bullet point list consisting of 3 questions and answers.
Our first question is for Chris. And my presenters, if you could please come back on video during the Q&A period. Chris, because this will require an ATO, does NIH offer to help sponsor this?
Chris appears on the call.
To be clear, an ATO is not FedRAMP certification and does not require sponsorship. The offer may include the cost breakdown for the fees associated with receiving an authorization to operate an ATO, because that will include a third-party controls assessment. But in terms of FedRAMP certification, that's not something that we're offering to do in the first period of the award, but something that could be considered in subsequent periods.
Great. And is it sufficient for the collaborating entity to have the ATO?
So to be clear, yeah, an ATO is specific in terms of the relationship between an awardee and a program. And so this is specifically for this engagement. So you won't show up with an existing ATO. It's a process you'll have to go through with us. You'll have to author a concept of operations. You'll have to go through a controls assessment, et cetera, in order to receive the capacity to move forward. That process typically takes anywhere from 6 months to a year, depending on how prepared the awardee is to do that work. And so we will work with you to do that, and we'll be in parallel doing the other work in the program at the same time.
Great. The next question is for you on security clearance. Is a public trust or higher level security clearance required for the offerer's team members working in the CLAD?
No, the CLAD award is being implemented through other transactions authority as an extramural project, and no federal clearances will be required for the staff.
Slide, questions and answers, human subjects research protections. A bullet point list of 2 questions and answers.
Perfect. Lou, the next question is for you. Will the CLAD offer be required to have their own IRB as part of the team?
Lou appears.
Right, thanks. So The CLAD offer will rely on a single IRB that we have for all of us. We'll put a reliance agreement in place, but the offer should have and hold a federal-wide assurance for the protection of human subjects and have relevant policies described within their assurance. The awardee is also expected to prepare materials related to each data linkage that is necessary for submission to the IRB and should be prepared to answer questions from the IRB.
Perfect. And then Lou, will all CLAD team members of the offer be required to have active human subjects research protected training and certification?
Thank you. Yeah. So there are some key personnel that we would like to have human subjects research protections training, and we're not specifying where you should go for that training. You may have an internal program. Lots of people go through Citi. Other people in the past have used NIH training, although I don't think that's publicly and freely available anymore. But nonetheless, the principal investigator, the program manager, and the de-identification disclosure expert should have that training and certification. The training should be updated regularly. I think we're being relatively reasonable about this, and that the training should not exceed 5 years for recertification. And then anybody who has access to the PII data that's part of CLAD should also go through that training and adhere to the 5-year recertification.
Slide, questions and answers, data linkage platform. A bullet point list of 2 questions and answers.
Great. Next one's for you as well. The requirements state that the data will be exchanged with the DRC, implying some sort of bi-directional flow. What data will be coming from the DRC to the CLAD data linkage platform?
Yeah, so to execute the work as part of CLAD, we will need PII data coming from the DRC to CLAD. So PII for sure. There may be some other important information that we need as part of making linkages, but certainly count on PII data coming over. It's also plausible that if we end up using PPRL technology, there is some work that the DRC has done with us related to some of these experiments, and we may want to reutilize tokens that have already been created by the DRC. So primarily think about it as PII, and all of this data is going to be going back to the DRC. So anything that we produce as part of CLAD that's going out to the workbench, the data, the documentation, and tools will be moving back to the DRC.
Okay, great. And does the government have a preferred provider for the data linkage platform and for privacy preserving records linkage tokenization? Man, tongue twister.
That's a hard one to get out. You'd have to say PPRL like 10 times till you get it straight. No, we're really neutral to this, and thank you for asking the question. We had this question from a number of folks during that period between the notice and the ROA going out, and we really are neutral. We don't have a specific platform provider in mind. We don't have a specific provider for PPRL technology in mind. We really remain neutral to it. But the platforms and the tools that are used, they have to meet the requirements of the ROA, and so look carefully through the functions that we've described. We're neutral to it, and we're also not expecting you to come in with a platform that's already up and operating. It could be something that you build from scratch. It could be an existing platform that you want to modify because you think it'd be great for CLAD, or it could be something that's already built and satisfies all the requirements. So we really remain neutral to both of those.
Slide, questions and answers, data linkages. A bullet point list of 2 questions and answers.
Lou, is the primary cause of death expected on every death record linked? Can NIH provide examples of other relevant data that is expected for that mortality data?
Yeah, thank you. So this is a really important endpoint for research, and we're really excited to have the opportunity to work on that on this data linkage during the base period. There are different providers of mortality data, and we are not expecting you to go for one versus the other, but they do provide other types of data with mortality, that being, whether the person has died or not. But the underlying cause of death for each of those linked individuals is particularly important, and there could be multiple underlying causes of death, and so we certainly want that. Some of the other elements that we might be interested in are age of death, where the death occurred, the date of death, marital status, etc. But for this linkage, as well as all of the other linkages, you'll notice that there is an objective up front, and that objective is to uncover and do a requirements gathering piece of work with us and the awardee to work through all those details. But those are some examples of the additional data related to mortality that we would consider incorporating into the data set.
Great. And would NIH or the CLAD or awardee establish the relationship with the Environmental Justice Index coordinator to link to other All of Us data?
Yeah, thank you for that question. So, of course, we've got very strong relationships with partners at CDC, and we work a good bit across many federal partners, and CDC is certainly an important one of those. We do not currently have a relationship with the Environmental Justice Index coordinator, and we would really like the awardee to establish that relationship, but we would do that in concert with them.
Slide, questions and answers. A bullet point list of 2 questions and answers.
And Jessica, a question for you. Regarding the recipient's pre-existing software platform or other trade secrets and materials, the terms and conditions contain contradictory terms on whether NIH is expecting to have use of that software platform, trade secrets and materials only during the term of engagement or perpetually. What is NIH's expectation?
Jessica appears.
Yeah, thank you, Tara. Yeah, per the ROA, the terms and conditions attached in Appendix A is a baseline for other transactions agreements awarded under the All of Us research program. The NIH will modify these terms and conditions throughout the selection process. Requests by offers to modify these terms and conditions will be considered by the NIH on a case-by-case basis and negotiated as deemed appropriate. The discussions and negotiations of the terms and conditions will take place with the invitees of phase 2 and 3. Thank you.
Great. And can bidders add rows and columns to Appendix F as needed to reflect their accounting system setup and specific cost elements they're proposing, as well as profit versus fee?
Yes, the vendors can add as many rows and columns as needed to reflect their accounting system setup and the specific cost elements they're proposing, as well as profit and fee.
Slide, questions and answers, cost and pricing information. A bullet point list of 2 questions and answers.
Great. And can you also provide clarification on whether fixed price models based on commercial pricing are eligible for the program?
Yes, due to uncertainties and the flexibilities needed in the project, a firm fixed price agreement would not be appropriate. Therefore, a cost reimbursable or cost plus fixed fee payment agreement would be needed. The offer can have subawards with fixed price labor rate agreements for commercial services or fixed price commercial products. Any firm fixed price cost shall still be broken down to reflect the labor categories, the hours, and an itemized list of the materials and equipment and travel in the proposal.
Okay, and can you clarify if all personnel in the cost proposal must be named individuals? Can there be unnamed TBD individuals included in that cost proposal?
Only key personnel must be named. So the unnamed TBD individuals may be included in the cost proposal for non-key personnel.
Slide, questions and answers, cost and pricing information. A bullet point list of 3 questions and answers.
All right, great. And under Section 8 of the ROA milestone plan, it asks for a table with a column for estimated total cost in dollars. Is the NIH permitting offers to include top costs within their technical proposal?
The costs of the milestone plan are high-level cost estimates for each milestone and should match directly with the formal cost in the cost proposal.
And can you confirm whether ROA Section 11 should be submitted separately as a PDF or along with Appendix F in Excel or included in the technical proposal as one submission document?
Okay. The cost proposal along with Appendix F should be submitted as a PDF and included with the technical proposal submission in the NIH ERA Assist system.
All right, great. And since ROA Appendix F only gives breakdowns through milestone 12 and the first 18 months, where should bidders provide optional cost breakdowns?
Cost estimates for the optional periods are not being requested in phase 1 proposals, but may be requested in phase 3 for planning and budgeting purposes.
Slide, questions and answers, eligibility and partnering. A bullet point list with 3 questions and answers.
Got a few more for you, Jessica. Are for-profit entities and small businesses eligible for the CLAD award?
Yes, CLAD is open to all entities listed in the ROA Section 6 eligibility information, including for-profit organizations and small businesses. There is no specific set aside for small businesses in this award.
And will the program provide potential collaborating partners for the applicants?
No, offers are encouraged to seek out partners for strong solutions, cooperative working relations and collaboration with the All of Us research program and program partners.
Are applicants expected or required to apply to all of the CLAD cores?
There will only be one award for CLAD, so offers are required to support all 4 cores. Offers may apply for the award on their own or as a team. Offers are limited to 1 submission, but may be included as a partner on more than 1 submission. Staffing is to be decided by the offer and partners. This should be done in a way that is logical and supportive of the key functions.
Slide. Closing. A numbered list. 1. ROA informational webinar slides and questions and answers will be posted as an amendment on sam.gov. 2. Follow this opportunity on sam.gov to get notifications to amendments. 3. Email any inquiries to all of us DTPD award requirements at nih.gov. 4. Questions must be submitted at least 14 calendar days prior to the proposal due date, April 17th, to ensure a response.
Great. Well, thank you guys so much. Those are all the questions we have prepared and that were submitted ahead of time. Any questions? I know that Lou and Chris have been answering questions in the chat, so you all should be able to see those. Those will also be included and posted within the post documents on on sam.gov. And as a reminder, today's webinar was recorded. Both the recording and the Q&A document will be posted as amendments to the ROA on sam.gov in the coming weeks. And this concludes our webinar. Thank you all so much for joining us today.